Welcome to the Learning Zone here at Philips. I'm delighted to introduce the next presentation focused on improving patient outcomes through automating bedside clinical decision support. Please join me in providing a warm welcome to our speakers for this session. Dr. Renuka Mehta is a pediatric intensivist at the Children's Hospital of Georgia at Augusta University Medical Center since 2004. And I'm Hassan Zaidi with Philips Healthcare, responsible for leading the client results program for long-term strategic partnerships. We're excited and thrilled that you've joined this session. I will now turn it over to Dr. Mehta to kick off our presentation.
Hassan, thank you very much for inviting me to do this presentation. As mentioned, I'm a professor at Children's Hospital of Georgia, working in Department of Pediatrics as an intensivist for over 15 years. I have a great passion in taking care of children, those who are sick, and I have also seen the evolution of how these management of these kids have changed over the course of time. It requires great teamwork, critical thinking, ongoing education, and embracing the changes. So our hospital, which is located in Augusta, Georgia, has 165 total beds, which some are in intensive care, intermediate care, and neonatal intensive care. And half or more are in partially monitored unit, which we call it general medical unit, general surgical unit, and epilepsy unit. The challenges in taking care of these patients are not unique from nationwide. Next slide, please. So what have we noticed over the course of last few years? That taking care of patient in hospital has changed because of patient safety, improvement in technology, improvement in taking with the home health care, and also demand from insurance company. So what we are seeing now, that our patients, those who are admitted to hospital, are far sicker, and they are also discharged much more earlier. Next slide, please. You would see that our admission rate apparently going down, but actually our observation number, which means that patients are staying less than 48 hours. So the numbers have, total numbers have not gone down, in fact have gone up, but we have far more sicker patients in hospital setting. So what are our challenges in caring for those patients? So the important we have noticed is, since these patients are more sicker and nurses are the front end monitoring them far more closely, now they have to take care of patients, those who are far sicker, they have more medical needs, they probably need more medication, so nursing staff is spending more time rather than being at the bedside. Next slide, please. So I've just started already talking about challenges in caring for those sick patients. So we'll go through that. So the first thing is, obviously, I'm being a medical director of CPR committee of Children's Hospital of Georgia for last 14 years, and I oversee the whole process. So one thing we all know, pediatric code blue, which means cardiopulmonary arrest, is bad. We do not want any child to have a pediatric code blue or arrest in partially monitored environment or non-monitor environment. As we know, if children will have a code, their outcomes are not great. Next slide, please. Our studies show that approximately 16,000 of American children suffer from cardiac arrest each year. However, if there is an in-hospital cardiac arrest, we only have 27% of those children will be able to be discharged from hospital. And some of may even have neurological devastation. Fortunately, the kids under 5 years do well. So obviously we cannot prevent 100% of pediatric cardiopulmonary arrest, but we want those to be happening in monitor environment in ICU setting where we are much more prepared, because when these arrests happen in the floor setting or non-monitor environment, it takes the team to arrive there and they are not prepared. However, we have a good news about our pediatric patients, that the studies in the late 90s were shown that the patients, those who were having cardiopulmonary arrest, they had abnormal physiological parameters way before the arrest happened. It could have been 12 hours or 24 hours, and they continue to deteriorate. And definitely, approximately in 66% of cases, there were definitely physiological parameter changes towards deterioration 6 hours prior to arrest. So this was a catch situation, and people felt that there are early warning signs which could be implemented in reducing the cardiac arrest. Next slide, please. So we had several nurses with a lot of experience could identify those patients, but it was not possible for the nursing staff who had just came out of training and had not much of experience in caring for sick children. So we came up with pediatric early warning score. As you all have learned, that if we can prevent the deterioration or minimize it, the patient's outcome will be much better. And that's why pediatric early warning score was developed in early 2000. This is an objective assessment tool which has been validated, and it helps in assist in detecting children at risk of deterioration. So if we look at the graph, you see as the severity of illness increases, patient care needs also increase. And if we intervene before it rises to arrest area, the patient is going to do much better. In order to take care of that part in general pediatric floor, the rapid response team has been developed in our institution. We call pediatric evaluation team, and they can come and intervene once the team or nursing staff in the floor calls for help. As you see, the studies have shown that 85% patient who had abnormal Pew score within 11 hours of event if patient had a code blue in general pediatric floor. So we took all this information and we implemented our Pew's protocol in 2012. Next slide, please. So what did this involve? It involved training our healthcare providers, nursing staff, physicians, respiratory therapists, pharmacists to learn how to do early warning score. So we developed the scorecard, we developed the Pew's algorithm, and other documents which could help them to start implementing and using it on a daily basis. So the nurses started, or they were supposed to do Pew scoring on every patient every 4 hours with their routine vital sign and follow the protocol if there were deterioration in their parameters, which means they may have to do it every 2 hours or every half an hour or every hour. So what happened doing this, starting this implementation of manual documentation of Pew score? It was much better. Next slide, please. Much improvement from having no Pew scoring. However, over the past 4 to 5 years, we continue to notice that we did not have 100% scoring because nurses had to do more jobs, take care of sick patients, so they had more workload. We also had inaccurate Pew scoring. As if you look into Pew scoring card, there are several elements to remember, and it's not easy for the nursing staff to remember all those points. It requires a lot of training, and with hiring, rehiring, it's always not had been challenged to train them regularly. As a result, we did see improvement in calling for help and minimizing on pediatric code blue or some adverse outcomes which led to staff being upset, since all the healthcare providers taking care of kids want to do best while they are providing the care. It is devastating for them. And on top of it, since they had to do manual documentation, it was more work for them, so that led to low satisfaction. And that's why we came up, next slide please, with the solution. So what is the solution? We implemented in August 2018 of this automated pews at bedside, so that all our patients in non-monitored or partially monitored environment get this vital scores done automatically, which is fed into their electronic medical record. And then it's much easier on nursing staff to do their pew scoring. They don't have to remember the vital signs, and they are able to score. And if patient has higher pew score, they are able to call for help much more earlier than it used to be. So we implemented in our general pediatric medical floor and general pediatric surgical floor. And we compared our results from the manual documentation to implementation of this automated pew score. And now Hassan will take over and give us all the results.
Great. Thanks, Dr. Mehta, for taking the audience through the challenges associated with the manual pediatric early warning scoring calculation and documentation. As you mentioned, I'll shift our focus now to customer success and outcomes as it relates to the Philips IntelliVue Guardian software. To provide a bit of context, Philips and Augusta University Health entered into a first-of-a-kind 15-year long-term strategic partnership in the US back in June of 2013 to focus on improving outcomes and delivering more effective and cost-efficient care. Because of our strategic partnership with Augusta University Health, we're committed to measuring the partnership impacts through the Client Results Program. The purpose of the program is to objectively and subjectively quantify the value of our relationship by measuring impacts related to the quadruple aim of healthcare. Each year, we prioritize, track, and report out on solution impacts on how the partnership is enabling Augusta University Health to improve outcomes, enhance the patient-provider experience, and reduce the cost of care delivery. As part of the Client Results Program, we worked with Dr. Mehta and the broader AU Health team to assess the impact of automating pews in the Med-Surg units. What you see here is the value analysis framework we use to capture key challenges, expected outcomes, and the process and outcome measures. The value analysis framework enabled us to align on 3 key pain points. Number 1, We wanted to reduce the time caregivers were spending on manual documentation related to PUEs. Secondly, we wanted to drive accuracy in PUEs documentation and calculation. And lastly, we wanted to realize interoperability benefits by integrating physiological parameters into the EMR system to drive patient and clinicians' experience. Over the next few slides, I'll cover key results from automation of PUEs at the bedside. I would mention that we collected 7 months of baseline data and then 7 months of post-implementation data on the two pediatric medicine and surgery units to show improvements. First, we'll dive into the results from the pediatric medicine unit on the 4th floor. As Dr. Mehta mentioned, before the automation of PUEs, the caregivers were calculating the score manually. After the automation, we saw a decrease in PUEs inaccuracy by 75% in the pediatric medicine unit. This was a result of taking subjectivity out of PUEs calculations and ensuring the scores aligned across the unit and the pediatric evaluation team. Since the PUEs automation helped with detecting patient deterioration earlier, we also saw an uptick in the pediatric evaluation team escalations by 80%. Caregivers were able to escalate PET calls more effectively to ensure the appropriate patient care was delivered to pediatric patients in a timely manner. The third metric we tracked was the unplanned readmissions into the intensive care unit from the med-surg units. As expected, we saw an increase of 41% in patients being transferred from the pediatric medicine floor into the pediatric intensive care unit. The automation of PUEs helped clinicians identify the right patient at the right time for early and effective intervention. Now shifting our focus to the surgery unit on the 5th floor, similarly to the pediatrics medicine unit, we saw a complete reduction of inaccurate PUEs. As mentioned earlier, this was a result of automating PUEs at the bedside to ensure alignment across the unit and the PET team. Due to the complexity of patients in the pediatric surgery unit, we decided to track how many patients triggered a PET call less than 6 hours of admissions into the unit. The Philips IntelliVue Guardian software assisted caregivers in identifying the subtle signs of deterioration at the point of care, hours before the potential adverse event occurred. This allowed the caregivers to respond earlier and in time to make a difference. To that note, we saw a 64% decrease in PET calls in the unit within the first 6 hours of the admission. Similarly to the medicine unit, we saw an uptick of 13% in PET calls post-go live in the pediatric surgery unit as well. To capture subjective and anecdotal feedback from the clinical staff, we conducted a 6-month post-go live survey of the Philips IntelliVue Guardian software to assess the overall staff adoption, awareness, and satisfaction. Overall, we saw 100% satisfaction among the caregivers. Among those who surveyed, 100% of the caregivers felt that the Philips IntelliVue Guardian software with automated PUEs was easy to use in their daily workflow. Moreover, the solution assisted caregivers to effectively detect patient deterioration in a timely manner. 88% of the respondents found that the solution was helpful in that aspect. In addition to the improvements in the clinical workflow, and Dr. Mehta touched on this, 85% of the caregivers felt that they realized time savings related to the automation of PUEs documentation. I'll share some of the verbatim feedback here. So what you see here is feedback from the caregivers across different personas. The underlying theme here is that the Philips IntelliVue Guardian software helped caregivers improve departmental communication by creating a standard for detecting patient deterioration in a more effective and timely manner. Building on to the voice of the customer, here's a quote from the nursing director. As you can see, the impact of having automated PUEs on driving clinical standards and critical patients' routine care. From a floor nurse perspective, the pediatric early warning scoring automation helped adequately float nursing resources between the units without the need for additional training requirements on the protocols. This helped drive ideal patient and family experience across the different units. Lastly, from a patient care tech perspective, the Philips IntelliVue Guardian software allowed the staff to spend more time with their patients rather than on non-value-added tasks such as manual documentation. In summary, by partnering closely with Dr. Mehta and the AU Health team, through the Client Results program, we were able to quantify the impacts in a tangible manner and ensure that the Philips IntelliVue Guardian software delivered on the expected benefits and objectives that were tied to the quadruple aim of the healthcare. I will now hand it back over to Dr. Mehta to bring this presentation to a close by sharing a few planned next steps and to sustain our positive journey at AU Health.
Thank you, Hassan, again. So obviously our partnership with will continue. We are happy with this outcomes. Our staff are continue to stay satisfied. So obviously, as mentioned, we are going to have continued measurement efforts. We are re-looking into what else points we can have so the Pew score can help further. So we are actually minutely looking into if there is, whenever there's increase in PET call on a particular group of patients, how can we minimize their deterioration. So one of the example is with the evolution, we have many patients with tracheostomy and on home ventilator are also admitted to general pediatric floor, and they are high-risk patients. So we are trying to explore how can the Pew score helps us to identify their deterioration or plugging of their tracheostomy tube. The other interest I have is that how documentation of this Pew score might help during times of winter month when we have more workload related to admissions with respiratory illnesses, etc. We will continue to follow up with our staff satisfaction, which, you know, I spoke to them last week and they seem to be happier, continue to stay happier. And then obviously we would like it to extend to our adult unit as well. So overall, this is a great journey with our partnership has come up with leading to patient outcomes going in positive direction. Thank you very much for listening to this talk.
Thank you, everyone. Thanks, Dr. Mehta.